right, let's get started here. All right, so first of all, thanks everybody for being on this. Before we actually get started, I will tell you with quite good confidence that if you got between 80% or so of these correct, I will guarantee that you will pass the dermatopathology part of the board. Okay, that is a guarantee. If you got 70%, 60%, you probably will pass. If you're in the 40 to 50%, I would recommend doing a lot more work. Now, all of you guys are on here at different stages of your training. You may have first-year residents. Don't worry about it if you get 40 to 50%. It's a good sort of tee up for you. Those of you who are going into your third year, or maybe those of you who are third years, especially those who are third years getting ready to graduate, if you're not getting 70, 75 or more percent of these, I would really dedicate some significant time to dermatopathology. One of the things about the board is that you do have to pass the Dermpath part to pass the entire board. So in other words, you can do greater than basic science, surgery, all that stuff. And if you don't pass the path part of it, you don't get to go on. And I had a friend of mine years ago who he's a resident and he kept flunking the Dermpath part of the board. He passed the other stuff, but he couldn't seem to get this part back. And I finally tutored him and he passed it. So anyway, make sure you're hitting those targets so you feel comfortable. And the old saying of, bleed in practice, sweat in battle, I would strongly recommend testing yourself hardest way you can on this stuff now. So when you get into the board, you just feel like, hey, this is no big deal. You're almost insulted that they're insulting your intelligence because the questions are so easy for you. So these basically don't have any history. So that's a little bit bleeding in practice because you may get some history on the board itself, but on these tests here, we're just giving you what's the right answer. And so here we've got a choice, and the board gives you 5 choices to choose from. So here the right answer is a fixed drug eruption. And while there is some evidence of some post-inflammatory pigmentary alteration, there is also interface dermatitis with dyskeratotic keratinocytes and deep melanophages with eosinophils here. So it isn't only just post-inflammatory, it's got an eosinophilic infiltrate. And the classic pattern of fixed drug eruption is superficial and deep infiltrate. It can even be denser than this. It doesn't have to be, but you get melanophages that are relatively deep and denser usually than in some of the other forms of post-inflammatory pigmentary alteration. Notice these are down here in the upper reticular dermis and even around that blood vessel there. So the EOs, interface, EOs, deep melanophages, fixed drug eruption, these occur at the same site over and over again. So that's why that's the best answer here. So hopefully you guys got that. Okay, next question. We've got a punch biopsy taken maybe from an area near palm or sole. You've got a psoriasiform epidermal hyperplasia, and you've got this classic, beautiful example of this pale upper epidermis with a broad zone of porokeratosis over a broad front. There's no neutrophils in the cornified layer. There's no real marked psoriasiform hyperplasia. There's a little bit of psoriasiform hyperplasia. There's some ballooning degeneration in a couple of areas here. The answer to this is Glucagonoma syndrome. This is one of the deficiency disorders, acrodermatitis enteropathica, zinc deficiency. All of these diseases look the same under the microscope. Biotin deficiency, pellagra, they all give you the same pattern, and they give you this ballooning degeneration. Sometimes it can be even more florid than you see here with this broad amount of porokeratosis overlying it here. So it's not Pityriasis rubra pilaris. Notice it's got a basket weave cornified layer on top of it. You don't always see that, but you absolutely would never see that in PRP. It's not psoriasis, it's not a thermal burn. There's no necrotic keratinocytes. This is a deficiency disorder, glucagonoma. Okay, third example, and we've got what looks like a biopsy in which you have 2 different pieces. So the board might show you something like this. This is both a vertical and a horizontal biopsy, and we see that very commonly when we're dealing with alopecias. Okay, and so alopecia, we look here and you see that there's marked perifollicular inflammation with some lymphocytes targeting the isthmus and the lower part of the infundibulum and the upper part of the lower portion of the follicle. This is classic for Lichen planopilaris. Okay, this is not keratosis pilaris. It's not just garden variety folliculitis. This is a perifolliculitis. okay? And it's not follicular mucinosis like you'd see with mycosis fungoides. So if you see this pattern here, this is classic for lichen planopilaris. Here's another one. 2 follicles are involved. This may be a residual follicle or a little bit of lymphocytic infiltrate remaining. If you look at the horizontal section, you see this nice perifollicular fibrosis with lymphocytes surrounding it. So this is lichen planopilaris. And sometimes you'll see the same pattern in central centrifugal alopecia and in frontal fibrosing alopecia. They're not going to ask you to distinguish those histologically because they look virtually the same. So, but make sure you recognize this periisthmic inflammation with this fibrosis there. That's classic for lichen planopilaris. Okay. Next one, we got a shave biopsy here of a nodular and diffuse infiltrate. And as we go to higher magnification, a lot of these are histiocytes here. And you see these eosinophils, and you see this fibrosis surrounding these blood vessels here. Actually, they're not. There's a few histiocytes, but actually these are probably fibroblasts rather than histiocytes with neutrophils. This is a good example of what we're looking at here. Blood vessel, neutrophils, fibrosis surrounding the blood vessel, and eosinophils. This is a classic example of Granuloma faciale. It looks histologically very similar to Erythema elevatum diutinum. This is there's often a grin zone here, as you can see here. And I can't really tell what part of the body it is, but this actually could have been from the face. They took a shave biopsy, and most of the inflammation has really destroyed the possibly the pre-existing sebaceous glands here. But this is an example of the blood vessel. This is a chronic form of vasculitis with secondary fibrotic change occurring as time goes on. And again, neutrophils, eosinophils, and this perivascular fibrosis. A classic example of granuloma faciale. Now they've got a couple other things in the differential here that might possibly be confused. The only one I think you might run into might be angiolymphoid hyperplasia. Again, that's not going to give you the perivascular fibrosis. You get the blood vessels that have these very, very thick walled blood vessels with lots of large prominent endothelial cells. And you don't get the neutrophils in that condition. So that's not the best answer. So the granuloma faciale here would be the best answer in this diagnosis here. Okay, case number 5. This is recognizing an epidermal reaction pattern. And if we look at high magnification here, we see the classic example of epidermolytic hyperkeratosis. These individual keratinocytes have these pink basophilic and pinkish granules in their cytoplasm. There's also this pallor of the cells up here too. This is a nice example of epidermolytic hyperkeratosis. This can be seen in a lot of different conditions. So they're not going to ask you whether this is, say a solitary keratosis versus, congenital bullous and ichthyosiform erythroderma. They're not going to ask you that, but they might ask you to look at this and recognize the pattern where you see this. They might say this condition may be seen in which of the following conditions, and maybe have congenital bullous ichthyosiform erythroderma in that condition, for example, as a choice. So recognize this as epidermolytic hyperkeratosis. This is not the same type of change that you see in a verruca. You don't get this pink eosinophilic hyperkeratosis in association with a wart. So even though it's got some verrucous hyperplasia, this is not a verruca vulgaris. This is epidermolytic hyperkeratosis, and they're going to expect you to be able to tell those two apart from one another. So these keratohyalin-like granules here, this pink eosinophilic granular cell layer and cornified cell layer, that's characteristic of epidermolytic hyperkeratosis. Okay, next we've got a subepidermal blister here. Subepidermal blistering disease. They might show you this with an immunofluorescence picture. The way to tell these from one another is to look at the type of inflammation here. We've got tons of eosinophils in here and lymphocytes. So subepidermal blister with lymphocytes and eosinophils, diagnosis is bullous pemphigoid until proven otherwise. If they show you an immunofluorescence, they're going to have you demonstrate a positive IgG and C3 here. That would almost make it too easy, in my opinion. A couple of other choices here. They have bullous insect bite reaction. Well, that's not the best answer because you've got a nice, clear subepidermal blister without a lot of papillodermal edema and no spongiosis really to speak of. So this is a nice example of a classic subepidermal blister. It's not one that's developed because of spongiosis and papillodermal edema. It's happened because of the immunoreactants that deposit at the level of the dermatodermal junction here. So that's really not the best answer. Obviously not linear IgA or DH. Those are neutrophilic subepidermal blisters. So hopefully you all got that one without too much difficulty. All right, case 7, another blistering disease, but the blister here is in a different location. Here it's within the epidermis, and we know that there are 3 ways of getting intraepidermal blisters primarily: spongiosis, acantholysis, and ballooning. This is an example primarily of ballooning degeneration, where the cells are filling up with fluid, forming like a little balloon that then ruptures, and then you get a secondary blister with this reticular alteration, the residual little strands of cell membrane material and papillodermal collagen here. Papillodermal collagen strands are just trying to keep this blister from floating off away from the skin. And then if you look carefully, you get these pink inclusions inside the cells here. So this is a nice example of hand, foot, and mouth disease. And this was interesting because it's got some acantholysis over here too, which is just probably secondary to the inflammation. But this is a beautiful example. I'm sorry, not hand, foot, and mouth. This is herpes infection. This is not hand, foot, and mouth. This is herpes with the acantholysis over here. So these are the acantholytic cells here with the nuclear inclusions in them. This is herpes infection, not hand, foot, and mouth. I misread the answer here. So this is herpes, and these are the multinucleated giant cells of herpes that you see here. Okay, hopefully you all recognize this also. This is a fairly easy one that they probably will have in the board examination somewhere, either shingles or herpes virus infection. They showed this to us on our board. They'll show it to you on your board also. Okay, the next one, we have a fairly sparse superficial perivascular dermatitis with epidermal hyperplasia. The key to this diagnosis is looking at the cornified layer here. And we see this little area beneath the cornified layer where there's this crust. So this is basically a very, very superficial intraepidermal blister. And there's some neutrophils in this blister space here. This is an example of Bullous impetigo. If we did a gram stain, we could possibly see gram-positive cocci in here. There may be some little organisms here, right here, that you can see. Again, they're not unequivocally certain just looking at it with this, but they might show you a gram stain and show some gram-positive cocci here. So this is one of the subcorneal blisters. This isn't pemphigus. There's really no acantholysis, and the distractor is Pemphigus vulgaris. So you would obviously see acantholysis way down here if it was Pemphigus vulgaris. The blister is occurring way, way superficial. They probably wouldn't put superficial pemphigus as a distractor because you can see similar changes in both of those. But this is a nice example of Bullous impetigo. You see the neutrophils sitting in that space just beneath the granular cell layer. Very, very superficial blister here. Variable amounts of inflammation. Often you don't really see too much. You can see some neutrophils and eos in the dermis, but you don't have to. Okay, next one, case number 9. Here we've got an example of a shave biopsy, and you can see it's got an abnormal cornified layer at low power. It's also got the thick epidermis with some irregular psoriasiform hyperplasia. When we start looking at that cornified layer, it's got this classic example of the so-called checkerboard pattern. We've got parakeratosis alternating with orthokeratosis, both vertically, ortho, para, ortho, and horizontally, para, ortho, para, ortho. This is classic for Pityriasis rubra pilaris. And notice it's got these really thick, bulbous epidermal redi. That's not really the classic elongated, thin epidermal redi we see in psoriasis. To get these fat, bulbous redi, they need to go on Ozempic here. And we've got the nice checkerboard pattern of cornified layer change. And then we've got this follicular plug. We've got that nice change of ortho and alternating ortho and parakeratosis right there in the follicular plug. So it's a beautiful example of PRP. You can sometimes get a few neutrophils in the cornified layer of PRP. Don't let that be a distractor to you. If you see a little bit of that, but you got everything else that looks like PRP, don't choose psoriasis. So again, this doesn't look like psoriasis. And if they're going to show you an example of PRP, it's going to be something like this. It's going to be classic. There's not going to be any question about the diagnosis. They don't want to have people challenging the exam. They don't want lawsuits. So they're going to show you pretty classic examples where you've studied in your residency program, you should be able to get the answer correct. Okay, here's an example of another biopsy taken from the scalp. It's an alopecia. Normally, we should see about 8 to 10 follicles in antigen here. We've got these miniaturized follicles here that are all shifted into the same stage at the same time with a residual lymphocytic infiltrate. This is Alopecia areata. Here's the swarm of bees sitting right around these little hair follicles that have all been shifted at the same time from antigen to catagen, and now they're in telogen, okay? If you saw telogen effluvium, they are not all synchronized like this. If telogen effluvium's got maybe just a lower antigen to telogen ratio, but here it's basically zero. All of these have been shifted into telogen. You never see that in telogen effluvium. It's classic for alopecia areata. So you don't have to see the bulbs, swarms of bees, the bulbs, the hair follicle. They'll probably show you that, but you don't have to see it. You can still make the diagnosis of alopecia areata when you've got this pattern here. So it's not trichotillomania. There's no trichomalacia. There's no damage to the hair shafts, although a lot of people that get alopecia areata get secondary trichotillomania because they say, oh my goodness, my hair's falling out, and they kind of help it along. But they're not going to show you that. If they can show you something that'll be just like this, it's a pretty classic example of alopecia areata. Okay, next case. We've got another punch biopsy taken of inflammatory skin disease here. And we've got a beautiful example of an interface dermatitis. There are lymphocytes lining up here at the basal cell layer. We all know there are two types of interface dermatitis, vacuolar and lichenoid. And so this will be more of the vacuolar interface dermatitis. Notice that there's a basket weave cornified layer. So this process happened acutely. It hasn't even had a chance yet to make much in the way of porokeratosis. And if we look at higher magnification, we have these dyskeratotic keratinocytes, these little vacuoles at the basal cell layer, infiltrate consisting almost wholly of lymphocytes. And then we've got these dyskeratotic keratinocytes. Now we're getting a little bit of abnormal cornified layer being formed up here, but it hasn't really had a chance yet to make it all the way up to this area. This is a beautiful example of Erythema multiforme, classic example of EM. And other things that are as a choice, they've got subacute lupus. Well, there's no mucin here, and usually subacute lupus doesn't happen this quickly, and you get some abnormal porokeratosis up there, so that's not the best answer. It's not a lichenoid process, which would rule out lichenoid drug eruption. It's not graft versus host disease. Again, that's a more chronic process, and it's obviously not lichen planus. So a nice example of erythema multiforme. Once again, happened acutely, hasn't even had a chance to form an abnormal cornified layer yet. So beautiful example of that. Hopefully you all got that one right also. Another example of an immunobullous disease here with an intraepidermal vesicle. And notice that there is the epidermis, the cornified layer in the very, very uppermost part of the epidermis being sloughed away. We've got acantholysis, and the acantholysis is situated very, very high up in the granular cell layer, and maybe the spinous cell layer here. This is an example of pemphigus, superficial pemphigus, and we don't know whether it's pemphigus erythematosus or fogosylvagum or pemphigus. Superficial pemphigus is really kind of all we can really say here. It could be any of those. They're not going to ask you to distinguish between that just on a routine H&E biopsy. But if you see this kind of superficial acantholysis, you should immediately think of one of the forms of superficial pemphigus, probably foliaceous, but we're not really sure about that. This one says erythematosis. That's fine. That's the only choice here. That's a superficial type of pemphigus. So hopefully you didn't choose Pemphigus vulgaris. The acantholysis would occur way down in this area as opposed to being superficial like this. So again, a form of superficial pemphigus, very, very straightforward, and hopefully you didn't have any trouble with that. Number 13. Okay, we've got a punch biopsy once again of an inflammatory skin disease. It's got a psoriasiform pattern here, very regular psoriasiform hyperplasia, long, thin epidermal reedy, long, thin, dilated, tortuous blood vessels. You've got porokeratosis with neutrophils overlying it. You got some neutrophils up here in the epidermis and in the cornified layer. This is a classic example of psoriasis. So hopefully everyone got this right. And so this shows the classic micaceous scale and the neutrophils of the cornified layer. This has got virtually every feature of psoriasis. And they're probably going to show you something like this on the board if they want to ask about psoriasis. They might even show you something like this and ask you a second order question, like which drug might be a good treatment for this. And they might ask you something about a biologic or something along those lines. So it really doesn't look like any of the other choices. Hopefully nobody made the mistake of choosing anything else there. Okay. Another example, a superficial and mid to deep perivascular infiltrate here. It's got a interface dermatitis superficially, and it's also got a lot of abnormal cornified layer change here. It's got porokeratosis, it's got neutrophils. It's got a very dense infiltrate of lymphocytes with some neutrophils. And notice the marked interface change here with the cells crashing into the epidermis. A lot of dyskeratotic keratinocytes and a lot of extravasated erythrocytes. Go down here, you can see the same type of infiltrate down on this hair follicle here. No eosinophils in this infiltrate. Classic example of Pityriasis lichenoides. This would probably be more the acute form, Mucke-Habermann type of Pityriasis lichenoides. But notice this cornified layer change, this kind of confluent abnormal porokeratosis going over a broad front with the interface change, the epidermal tropism here of the inflammatory infiltrate, the dilated blood vessels, and the extravasated erythrocyte. This is classic for Pityriasis lichenoides. So if they're going to once again show you something, it's going to look like this. This is a beautiful example of that hopefully all of you really could recognize this too. So it's not any of the other choices there. Certainly not. Secondary syphilis can give you a pattern like this, but there's no plasma cells here. So again, that would militate against that. Certainly it's not psoriasis or mycosis fungoides. Okay, next case here. And we've clustered most of our inflammatory diseases here at the beginning. We've got something near volar skin, and we started looking at this, got a lot of dilated blood vessels. I hope you could recognize that every one of these blood vessels here is plugged with this pink hyaline-like material. And there's extravasated erythrocytes, but a lot of these blood vessels are filled with this pink material over here. And the epidermis, not really necrotic yet, but I wouldn't be surprised if it doesn't get necrotic at some point. Look down here at the blood vessels surrounding these sweat glands, and none of these really look like they're necrotic yet, but they're probably going to become necrotic fairly soon. This is a nice example of cryoglobulinemia. All of these blood vessels are filled with this abnormal protein that's precipitated here. So this is a very thrombotic vasculopathy. There's minimal inflammation, but there's all these blood vessels are filled with this pink hyaline material. And this is not septic vasculitis. That's associated with an inflammatory infiltrate of neutrophils. We don't see any of that here. DIC, again, is going to give you more inflammation than we see here also. They probably wouldn't choose that as a distractor for you because that can also give you a vasculopathy. It's not leukocytoclastic vasculitis, no inflammation here. And it's not this so-called cutaneous collagenous vasculopathy, which is associated with the dilated blood vessels with thick PAS positive membranes around them without any thrombosed blood vessels. So the best answer here is cryoglobulinemia, pink hyaline deposits of material in those blood vessels. Okay, that's a little harder one than some of the others that we've had. Here's a beautiful example again of another interface dermatitis, and here it's got the classic lichenoid pattern, lichenoid infiltrate obscuring the dermatdermal junction with wedge-shaped hypergranulosis, hyperkeratosis, a beautiful example of lichen planus. So again, this is pretty easy. Hopefully you all got this without any difficulty. Now, lichenoid drug eruption, they put that in there. It's not as good of an answer as lichen planus because it doesn't have any eosinophils in it. You can get a lichenoid drug eruption without any eosinophils in it, But if you had to choose between those two, which is the better answer? And sometimes they do that. And it's tricky because you say, well, but they can both look the same. Well, yes, they can. But they say, which is the best answer? Which is a better answer? And so this has all the classic features of lichen planus, which usually in lichen drug eruption, it doesn't have all the classic features of LP. So that's a tricky way that the board tests you. And to me, it's partially unfair. It feels unfair when you're taking the exam. When I took the bar exam I just mentioned to you a minute ago, they had a lot of questions there that I really would have liked to have argued with them about. But they're saying, look, we're not saying that there's one right answer here. We're saying which is the best choice under the circumstances. And so when you're practicing medicine or practicing law, sometimes you have to make a decision of something that's the best decision to make under the circumstances. They're kind of testing that when they ask a question like that. So again, it doesn't look classic like a BLK. It doesn't have any solar lentigo changes. It's not on sun-damaged skin. It's not a good example of lupus, even though you can see lichenoid features in lupus. There's no mucin. There's nothing else like lupus. It's not mycosis fungoides, no epidermotropism. So again, you might think it's unfair to put a lichenoid drug as a choice, and they just be prepared. They might decide to do that to you. Hopefully they won't, but they might. So just be prepared for that. Okay, next example. We've got a biopsy that's got all these collections of neutrophils sitting in the dermal papillae and a little wee bit of an incipient blister. So you look at this and say, well, can I really tell this is a subepidermal blistering disorder? Difficult to be sure, but that actually is probably a real little incipient blister that's developing in a patient that's got dermatitis herpetiformis. It's got the classic collection of neutrophils at the tips of dermal papillae. Now, they might show you a blister and then off to the side, just these findings here. So be prepared for that. But in this biopsy specimen, we're showing you there's not even a real blister that's formed yet. And we still can make the best answer of DH. Okay, you've got linear IgA there as a choice. Why is that not the best answer? That usually doesn't just cluster at the tips of dermal papillae. You've got bullous lupus. That's also a subepidermal blister with neutrophils, but again, not the collections of the neutrophils at the tips of the dermal papillae only. Okay, so yes, those can give you subepidermal blisters with neutrophils, but this is the best answer of those three. Okay, so just don't drive yourself crazy. Don't overthink it. When you see this pattern, make that diagnosis and then move on to the next more difficult question. Okay, another example of a classic reaction pattern. We've got acantholysis, and notice the pattern of the acantholysis. It's present diffusely throughout the epidermis, all the way going down to the bottom, all the way going to the top, over a large part of these areas here. So this is the so-called dilapidated brick wall that we classically see in Hailey-Hailey disease. Okay, and that's the right answer. Now, these other choices have got acantholysis in them too. So these are a little harder to discern from. So you look at this low power, say, okay, acantholytic disorder, probably Hailey-Hailey, and you look down and say, well, they got pemphigus vulgaris there. Well, that shouldn't give you all this acantholysis above the areas. We're going to exclude that one. You've got Grover's. Well, there's a Hailey-Hailey subtype of Grover's, interestingly enough, but it's not as diffuse as this, and it won't involve hair follicles if they're present. Okay, that's focal acantholytic dyskeratosis. You've got Derriese. Well, that gives acantholytic dyskeratosis. Well, we've got a little bit of dyskeratosis here and there, but we don't get that as the primary finding. We're mostly getting diffuse acantholysis without a lot of dyskeratosis over a broad front. So we're not seeing the classic acantholytic dyskeratosis of Derriese. Now, don't just look at one area. Don't just say, well, I'm only going to look, oh, look here. Doesn't that look like pemphigus? Yes, it does. If you only looked right there, don't use one small thing to screw up your good diagnosis because it's screaming Hailey-Hailey everywhere else. Don't just look at one little area like that and say, well, maybe it really is pemphigus with some extra acantholysis. Don't do that. Don't talk yourself out of a right answer make sure you apply criteria, sort of like Dr. Spock. You want to go through and apply these criteria in a very objective way to the best of your ability, and then look down and see what choices are there, and then choose the right answer. Okay. The next one, we've got, you see low power. There's something going on here where there's loss of the epidermis centrally. And we look down at this and we see what kind of choices we are. We see this nice example of this column of porokeratosis with this dyskeratosis at the base. There's two of them. And so you can imagine what this looked like clinically. It was probably like a little moat of that thick column of cornified material with a little central depression. So this is a classic example of porokeratosis. Now, they probably wouldn't do this to you, but there is a condition that can look sort of like poro, this palmoplantar central hypokeratosis, where you basically get normal cornified material and this step off where you lose the cornified material. But that's not associated with the cornoid lamella. So if they were going to get tricky with you and put that in there as a choice, don't choose it, because this has the classic cornoid lamella here. Okay, it's got the cornoid lamella. So don't, talk yourself out of it when you've got something that's sitting here this classic. You want to make sure you choose the right thing. Now, they might even give us a second order question on this now, because they know that porokeratosis is associated with fumarate hydratase deficiency, that enzyme that was recently reported. So I would recommend learning about that, because they might show you something that they expect to get pretty quickly, and then ask you something along which enzyme has now been defined to be associated with this disease. So make sure you're aware of some of those things. They love to ask things when there's been something that's discovered about it, and especially if a dermatologist was involved in it. So, and I think there was a dermatologist involved in the discovery of that enzyme deficiency. So make absolutely certain that you're prepared for that. They might ask it in the basic science part. They might ask it on the Dermpath part. Okay. Another example here, we've got a beautiful example at low power of a superficial and deep infiltrate consisting of these dark staining cells, which are lymphocytes. So we all know there's a differential diagnosis of about anywhere from 5 to 8 things that can give you a mostly lymphocytic infiltrate in the skin. So then we look for other ancillary findings to be able to help us refine our diagnosis. If we see mucin, we think of lupus. If we see papillary dermal edema, we think of possibly polymorphous light eruption. If we don't see anything, we think of maybe Yesner's or figured erythema. If we see plasma cells, we might think of erythema chronica migrans. Okay, so you want to think about all those various things to kind of help you. Well, this one does have papillary dermal edema here, and it doesn't have any mucin. It doesn't have any interface change. And so the best answer this time is polymorphous light eruption. Okay, hopefully you all saw that. Notice there's no real epidermal change here. So you can imagine this looked like kind of a pink urticarial looking lesion in a sun-exposed area. And you have some other choices here. Bug bite, okay, that should have EOs. It can give you a superficial deep infiltrate with lymphocytes, but also eosinophils. It can give you papillary edema too, but there's no EOs here, so that's not as good of an answer. You got 2 at LE, again, no mucin. Got the papillodermal edema, not as good of an answer. So again, it's on sun-damaged skin. It's got some sun-damaged solar elastosis here. So again, this is an example of polymorphous light eruption. Nice example of that. Okay, moving on. We've got something else at low power that's got all this crust, and something's going on here in the epidermis. And as we go to higher magnification, you can see that it's once again an intraepidermal acantholytic process. Remember back to your Hailey-Hailey that we just saw a minute ago? Well, here we've got acantholysis occurring just above the basal cell layer. And also notice it's tracking right down to that hair follicle. Beautiful example. And this is Pemphigus vulgaris. Pemphigus vulgaris. And if you look over here, you can see that classic tombstoning, the single layer of the residual acantholytic cells at the base here. And the upper part of the epidermis is pretty much just sheared away. Now, don't look at an area like this and say, oh my gosh, that's Hailey-Hailey. It's got some suprabasilar acantholysis also. Again, look at the entire biopsy. Look at the hair follicle. Look at the single basic tombstone of cells that left at the bottom of this hair follicle. Look in this area. A beautiful example of Pemphigus vulgaris. This is not Hailey-Hailey. Okay, so you've got some of these same acantholytic disorders we saw before in the Hailey-Hailey distractors. You want to apply the same criteria here that you did there. And just because there's a little suprabasilar acantholysis, don't let that throw you off the fact that the vast majority of this is just above the basal cell layer here. Okay? And you can also get some inflammation down here too. Lymphs, some EO sometimes in pemphigus. Don't let that throw you off the mark either. Okay, punch biopsy once again. Got a superficial and deep perivascular infiltrate that's almost somewhat band-like at the top. And you can see in contrast to the case we just saw a minute ago with a polymorphous light eruption, these are not going to be all lymphocytes here. There are going to be some histiocytes here. There may be some other cells in here. And as we go to higher magnification, indeed, there are some histiocytes. They're forming this kind of poorly formed granuloma. And then we've got all of these cells here that've got this perinuclear halo that's got immunoglobulin. There are plasma cells. There are lots and lots of plasma cells here. So we've got a superficial and deep perivascular and perinexal infiltrate with granulomatous inflammation that's not forming classic sarcoidal granulomatous. It's not palisaded granulomatous with plasma cells. Hopefully you all thought of syphilis here. Syphilis can give a lot of different patterns in the skin. The classic patterns is superficial and deep psoriasiform lichenoid pattern with poorly formed granulomas and plasma cells. Here we've got more of a nodular superficial deep infiltrate with poorly formed granulomas and plasma cells. So again, this is secondary syphilis, not lichen planus, not lichenoid eruption. None of this is a fairly easy list of distractors for you. So on the board examination, they might put sarcoid here. That would be a little bit more difficult, but that doesn't give you the plasma cells in the infiltrate. They might put Crohn's. That'd be a little bit more unfair. I'm not sure I would want that. If I were writing an exam question, I'm not sure I should include Crohn's, but they might put syphilis, and this is not a very good example of syphilis. And all the plasma cells, probably really not a great example for Crohn's either. So again, good example, secondary Louis. Okay, next case. All right, so this one is not an inflammatory process. We've got an excisional biopsy here, big biopsy, and something's going on here in the dermis, and it's an asymmetrical process. This is a neoplasm, and we all know that what we do when we're dealing with neoplasm, we ask whether we think it's benign or malignant based on size, symmetry, circumscription. Well, this thing is pretty big. It's asymmetrical, goes from top to bottom. It's not well circumscribed, so it's probably going to be malignant. Is it epithelial or non-epithelial? I don't really see anything that looks like the normal stratified squamous epithelium here. I don't see any adnexal structures here that look like it's recapitulating here. So it's going to be non-epithelial. We're looking at non-epithelial lesions. We think of three main things at the level of a dermatology resident. We're thinking of fibrohistiocytic, we're thinking of neural, and we're thinking smooth muscle. And yes, there are lots of other things that can give you spindle cell morphology sometimes, but we're keeping it simple, stupid. We're keeping it simple for us, and we're going to keep it to those three things. Those are the three things the board examination is going to expect you to know. So is it good? So it's probably here, not neural. These look like they're angulated cells. They're not like these delicate cells that are swimming freely in a little fibromucinous stroma. These don't look like fascicles of smooth muscle, so it's probably fibrohistiocytic. So this is a malignant fibrohistiocytic neoplasm, and in this case, this happens to be an atypical fibroxanthoma. Now, they might show you this. They probably wouldn't expect you just to quickly answer this without any immunoperoxidase stains. So they might say this lesion was highlighted with CD10, this stained negatively for smooth muscle actin and negatively for maybe something like, SOX10 or something like that. So it's not a melanoma. And then they would expect the best answer would be, and you'd expect to know that that would be atypical fibrous xanthoma, or pleomorphic dermal sarcoma, which is basically the same thing, just bigger. Okay, so this is AFX. Fibrosarcoma, they probably wouldn't put that in there. They probably wouldn't put desmoplastic melanoma. So in this lesion here, they probably would give you something else to help you make a definitive diagnosis. But this is what an atypical fibrous xanthoma looks like histologically. Okay, let's take a look at this one. We've got a punch biopsy here, or maybe an excisional biopsy. Pretty big lesion. Fairly small, fairly well circumscribed, fairly symmetrical. And once again, you see that it's comprised of non-epithelial cells. So we're going to ask ourselves once again, is it going to be smooth muscle? Is it going to be fibrohistiocytic? Or is it going to be neural? As we look at this at higher magnification, we see these cells that look almost like little cigars. We see this pink material that almost looks like a fascicle of muscle. Here we see it in cross-section with these nuclei that are centrally located. So this really looks to me really, really good for smooth muscle. I don't see any mitoses. I don't see any atypical cells, so it's almost certainly benign. So the best answer here this time is a leiomyoma. It's not a leiomyosarcoma. It's small, circumscribed, no mitotic figures, no atypia. So you might get into the smooth muscle and you say, okay, I think it's a leiomyoma. And then you start look at it and say, well, gosh, there's leiomyosarcoma as a differential. And then you start looking and say, well, gosh, some of these cells may be atypical. Gosh, is it really a leiomyosarcoma? Don't make that mistake. It's still relatively small. It's well circumscribed. They got it all out with this punch or this little small excisional biopsy. Leiomyosarcoma is going to be bottom heavy, deep. They're going to be diffuse. They're going to have mitoses, atypical cells. So it's not a leiomyosarcoma, and it's not any of the other lesions that are listed here, these distractors. So nice example. And it's a nice contrast to the last lesion, which didn't really look anything like smooth muscle differentiation. Okay, let's move on to the next one. Okay, we've got a shave biopsy, and we've got this interesting morphology of this cartilage sitting here. We've got this epidermal hyperplasia overlying it. We've got fibrosis, we've got inflammation, we've got this thick cornified layer, and this is not on volar skin, and there's no cartilage on our volar skin, so we know it couldn't be that. So it's probably the nose or the ear, and it looks like there's no sebaceous lobules here, so it's probably going to be the ear. And so it's been rubbed with this abnormal fibrosis above this cartilage. This is a classic example of chondrodermatitis nodularis helosis. Beautiful example of that. So if they're going to show you this, that's probably what they're going to show on the exam. How does that process develop? It occurs as a consequence of chronic trauma to the ear. Another name for this in the old days used to be an ear corn. You can think of it as like a corn where it's been chronically rubbed. Somebody's maybe wearing a hearing aid, they're talking on the telephone a lot, something like that. And they basically just this chronic trauma that causes this pressure between the cartilage and the epidermis, and it creates this fibrosis and inflammation and leads to this focal cartilage degeneration and all this fibrosis above it. So it's not a squamous cell. There's no atypical keratinocyte proliferation. It's not pseudocyst of the auricle. Now, if you don't know what that looks like, you might look at this and you might say, well, what is that? Well, basically, that's due to trauma to the cartilage also, but it's more blood trauma. Wrestlers get that. And they get degeneration of the cartilage from inside out. And they get this oil that gets liberated from this when you go in and lance one of these things. So it doesn't look anything like chondrodermatitis histologically. It's also not relapsing polyhydritis. That gives you inflammation within the cartilage coming from outside in. Lymphocytes, we don't see any of that here. So don't fall for those. There are also cartilage disorders, and they might put them in there because there's cartilage here, but this is a beautiful example of chondrodermatitis. They could ask you that. That's fair game. Okay, here we've got a biopsy that's taken probably, they took a bunch of different pieces of it and just stuck it in the bottom. Okay, this isn't done by an excision or punch or any technique. So something's going on here, and this thing looks like it's pretty big. It's got 10 pieces of it here. And we're going to take a look at a couple of these pieces. We're going to look at this one first. And once again, we know this is a neoplasm. It's not inflammatory. And we know once again, is it fibrohistiocytic, neural, or is it muscle? We don't see any muscle, and we see these cells that are giving these what are called cartwheel or storiform patterns. Here, it looks almost like windmills in here. This, like something that Van Gogh maybe drew. These whorled spindle cell areas here, whirligig, if you will. That's classic for dermatofibrosarcoma protuberans. And the other thing that's classic is you get this honeycomb involvement of the subcutaneous fat. The fat is diffusely involved with the same process. And we'll look at this other piece over here where you see this beautifully in this situation here. So this is the classic pattern of DFSP. And the cells of DFSP are probably closer to fibrohistiocytic and maybe neural. We're not sure exactly what the cells are basically forming collagen. So they're probably more in the fibrohistiocytic category. They're not as angulated as that AFX that we saw a minute ago. But we know that the way that this develops, these are CD34 positive cells, and there's a molecular genetic transformation where platelet-derived growth factor beta, the gene for that, is fused onto the collagen A gene. So these cells are actually fibroblasts that have been turned on by that genetic mutation, and they're basically proliferating dramatically, producing collagen, but mostly the cells are just proliferating rapidly. So it's a beautiful example of DFSP. Nothing else really will give you this pattern that gets into the subcutaneous fat like this. Now, there are some CD34 proliferative conditions that can look histologically a little bit like DFSP. They're not usually this big and multinodular. They're usually plaques, CD34 positive medallion-like dermal dendrocytic neoplasm. Again, that won't usually get into the subcutaneous fat to this degree. Doesn't usually give you as much of the storiform pattern that we saw before. So that they probably wouldn't include that as a choice for you because that's also CD34 positive, but it's certainly not any of the other choices that are listed here. So when you see this honeycomb pattern, I want you to think DFSP pretty much until proven otherwise. Okay, we've got a nice little lesion here that looks like it probably shelled out. So we think of the two main techniques of biopsies that we do as dermatologists. Take a shave, punch, excision or incisional biopsy. Well, this is another technique where there's like a ball in the skin and you make a little incision overlying it and you just kind of reach in there and just kind of pops out of there. Kind of delivers like a baby out of a little cut that you put there. And we see that, classic with pilar cysts and things like that. Adnexal tumors can also do that. And so when you see that, it's almost always a sign of benign when you see that. So it's neoplasm and it's pink. Okay, so it's probably not going to be epithelial. So once again, we've got our three main non-epithelial lesions we're looking at. And as we go to higher magnification this time, we see this pink material here, and we see these little round structures here. We see these blood vessels within this thing. So, and the cells themselves, again, look like little cigars. They don't look like little nerve cells that are floating freely in this fibromucinous stroma-like area. We see these blunt cigars coupled with pink stroma. So we once again think of smooth muscle. Now, this doesn't look like that leiomyoma we saw a minute ago that was a piloleiomyoma. Here we've got a lot of blood vessels in here. And if you look over here, these spindle cells are blending imperceptibly into the wall of this blood vessel. So this is a nice example of an angioleiomyoma. So we had a piloleiomyoma a minute ago. Now we have an angioleiomyoma. So nice example of a different type of benign smooth muscle tumor, one from blood vessels, the other one from the erector pili muscles. Angioleiomyoma. Okay, number 28. Got a shave biopsy of a lesion taken on sun-damaged skin. Neoplasm, epithelial or non-epithelial. Well, it's certainly not classic squamous epithelium. If it's epithelial, it's going to be something like maybe neuroectoderm, and we kind of lump melanocytic in that category. And we see all of these melanocytes arranged as solitary units at the dermatoral junction over a broad front on sun-damaged skin of the face of a person. This is a classic example of a melanoma in situ. Hopefully this was pretty easy for you. Didn't have any real trouble with this. There's a choice in here of some inflammatory things. Solar lentigo might be something you choose, but hopefully recognize that these are all melanocytes, and they're arranged both as solitary units as well as nests at the dermodermal junction as well as above it. And they're tracking down these epithelial structures of adnexa here. Melanin, it's asymmetrical, it's broad, it's poorly circumscribed. So this is melanoma in situ. Okay. And a lot of times these develop adjacent to solar lentiginous. And if you look over here, there is maybe a little solar lentigo here. So you might say, well, there is a solar lentigo, but don't just look at one area once again. Look at the whole thing. Make sure you're looking at everything. Don't miss this and just focus on, this. So pretty straightforward example of that. Another straightforward example of this entity, taken from volar skin. There's a collection of mucin in the dermis with fibroblasts. Beautiful example of a focal digital mucinosis, or some people refer to this as a digital mucus cyst. It's not a cyst, as you can see. It gets called a cyst erroneously, but what it actually is a proliferation of these probably fibroblasts that are present in the periarticular space. They're the same fibroblasts that make the joint fluid, and it gets collected outside of the joint space, and it usually involves the area of the proximal nail fold and can cause damage to the nail plate itself. So digital mucocyst or focal digital mucinosis. Now, there's some other myxoid lesions listed in here, okay? It's not superficial acral fiber myxoma. This is purely a collection of mucin with the fibroblast. It's not pretibial myxedema. That's a broad zone of mucin over a broad front, not a small focal collection of it with fibroblast. It's not a mucocele. It's not a mucous membrane, and that's associated with, you see minor salivary glands associated with that. And it's not a cutaneous myxoma. That's basically, again, a collection of mucin, a puddle of mucin without the fibroblast situated usually on the trunk or extremity. So again, the best answer would be digital mucocyst or focal digital mucinosis when it's occurring in this location. So again, that would be a tough question if they put those others in there for you. It makes it a little harder if you have to choose between those or among those. Okay, another example of a beautiful example of a biopsy that's got the classic layer cake inflammatory infiltrate going from top to bottom, side to side, all the way down into the subcutaneous fat. And notice it's got these pale staining areas here. This is a palisaded granulomatous dermatitis, palisaded granulomatous with sclerotic collagen here. Collagen is the sclerotic collagen is present in the center of the palisades here. And it's both a dermatitis going all the way down to the subcutaneous fat. This is a beautiful example of necrobiosis lipoidica, NLD. Make sure you can recognize this pattern. It's a beautiful example. It's something you can diagnose pretty much almost at low magnification. Okay, and other choices here to choose from. It's not GA, it's diffuse. It's got sclerotic collagen. There's no mucin here. There's no mucin in the center of the palisade. It's not sarcoid, no sarcoidal granulomatous dermatitis here. It's not necrotic xanthogranuloma. There's no cholesterol clefts. There's no diffuse granulomatous inflammation. There's no significant degeneration of fat. It's not anything like that. And it's not nephrogenic systemic fibrosis because it's got the granulomatous inflammation that's palisaded. So hopefully you all could, got this one right as well. Okay, number 31. We've got a punch biopsy that's going down to the subcutaneous fat. And the main pathology this time is in the fat. Okay? And this has a pathognomonic finding. This has got the classic example of saponification of the fat. So this is not a true paniculitis. It's a metabolic problem where the patient has paniculitis secondary to pancreatitis with release of amylase and lipase causing degeneration of the fat, forming soap that gives you secondary inflammation in the fat here. So you need to recognize this. This is saponification. Basically, this is soap that is formed in the skin with calcification of the fat here and degeneration of the fat here. So this is a beautiful example of saponification of the fat. Doesn't get any better than this. Make sure you can recognize this. This is like molluscum. You got to recognize this and know what it looks like and then make the diagnosis. Really doesn't look like any of the other potential diagnoses in here. So hopefully you didn't choose any of those. All right, 32. Low magnification, the thing that strikes me is this. And this is an example of a paniculitis with vasculitis. So you get paniculitis, septal lobular, with vasculitis, without vasculitis. So this is a lobular paniculitis involving the lobule with vasculitis. And notice that there's relatively little inflammation in the fat. There's a little bit, but mainly just kind of picks out the blood vessel. And this is an artery, medium-sized artery in the fat. It's got neutrophils in the wall of the vessel, some fibrin in the wall of the blood vessel, neutrophils in the lumen of the blood vessel. So this is not secondary vasculitis. This is targeting the blood vessel. This is classic for polyarteritis nodosa. Nothing else in here looks like this. Erythema induratum, if you saw this, you would get extensive fat degeneration of all of the lobules will be involved. And you get granulomatous inflammation of the lobules. So yes, that can give you a lobular paniculitis with vasculitis, but you get all the degeneration of the fat with the suppurative granulomatous dermatitis of the lobules also. You don't see that here. So the best answer here, once again, is going to be polyarteritis nodosa. Okay, 33, we're about a third of the way through. May pick up the speed on the last 2/3 of this. We've got a punch biopsy that demonstrates a patchy band-like infiltrate of lymphocytes with, even at this power, you can see there's involved in the epidermis. This is a classic, perfect, doesn't get much better example than this of mycosis fungoides. So this is what they're going to show you on the exam. They're not going to show you a subtle patch stage lesion that's got a little bit of epidermotropism. You're going to see this. And hopefully you'll be able to recognize that this is massive epidermotropism here of these lymphoid cells within the epidermis. You don't have to have protease collections to get MF. Just involving the epidermis like this. This is the eyeliner sign, the classic single cells of atypical cells at the basal cell layer. That's another sign of MF. Thick collagen bundles, telangiectasies. That goes along with the atrophic poikilodermatous features we see with MF. And here you see perhaps some protease collections being performed. Notice the very atypical lymphoid cells. They're convoluted. So beautiful example of mycosis fungoides. I don't think here any of the other choices would make any sense to you. So hopefully you quickly got that diagnosis as well. Beautiful example here of a disease in which there is a Gren zone that you can see at low magnification, not involving the papillary dermis, as opposed to the last case of MF that did. Low magnification, you can see that these are also going to be lymphoid cells. They're blue. They're not forming nodular aggregations. They're forming this diffuse aggregation here in the dermis. And there's also cells between and among collagen bundles here. These are very, very atypical cells here. And I hope you recognize that as well when you took a look at this. This is a nice example of leukemia cutis. Notice these cells are present in cords and strands between the collagen bundles. They may even be present within some blood vessels. Not sure if we're seeing that here, but this is a nice example of leukemia cutis. Not MF. Again, no epidermotropism. It's the opposite of that. It's not a marginal B zone cell lymphoma. That doesn't give you the cords and strands of cells we see here. That usually does not give you a Gren zone to the degree that you see here. And that's going to give you a lot more large atypical lymphoid cells in forming a large nodule or tumor, not like this, which is secondary cutaneous involvement. Again, nice example of leukemia cutis in this case. Okay, number 35. Punch biopsy here, fairly sparse infiltrate, so not too much inflammation here. Hopefully you can appreciate, again, if this is an inflammatory process, it's going to be a very sparse superficial perivascular dermatitis. And we know that there's the 9 patterns of inflammatory skin disease. There's inflammatory neoplastic, but there's also hamartomas and deposits. So don't forget about those either. And this happens to be a deposit. You can see that there are these widened dermal papillae here forming this ball and claw-like morphology around this amorphous pink material. This is a gorgeous example of macular amyloidosis. Macular amyloid. Now, they chose some other pigmentary disorders, and so you need to recognize that, yes, there is some reticular adrenal hyperplasia here, but there's also the amyloid. So you must recognize the amyloid here. If you don't see this, you could choose CARP, or you might choose post-inflammatory pigmentary alteration. Because yes, there are some, melanophages here. They're often melanophages associated with macular amyloid. But recognize the ball and claw morphology of these epidermal rete here. And you can recognize the amyloid. You don't need a special stain. You don't need Congo red. You don't need crystal violet. This is recognizable using routine H&E stain here. Okay. Another example, very sparse perivascular process here. So we're not thinking there's going to be a lot of inflammation here. But notice that there's some abnormality going on in the dermis here. This is another one of those things that you need to be able to just recognize by seeing this, and it goes into your brain, and it's in your dermatopathology encyclopedia of your brain. These are the classic fibers, elastic fibers that are caused by application of hydroquinone and ochranosis. Yellow bananas in the dermis equals ochranosis, okay? So this is a beautiful example of cutaneous ochranosis. And we got other choices here. We got Monsell's tattoo. That's an iron-containing process. Carbon tattoo doesn't look anything like this. Kraton deposition. Do you know what that looks like? It can kind of give you a slightly golden brown discolored pigmentation and some histiocytes in the dermis, but it doesn't give you these brown, yellowish bananas in the dermis like you see here. Pathognomonic for cutaneous ochranosis. So make sure you know what this looks like. Make sure you can recognize that. They might ask you that and they say this has been associated with what toxicity, and expect you then to know that it's associated with hydroquinone. So that's another trick they could pull on you. So we've got kind of a little group of lesions here that all show these deposits of things. Here we've got another very, very sparse infiltrate of almost nothing. It's near mucous membrane, and we've got this blackish material down here. And it's black. What is it? Notice that it's also involving these fibers here. They're staining these coiled elastic fibers in the dermis. And this isn't even dermis. This is lamina propria, okay? And what this is a silver amalgam tattoo. Back in the old days, when people used to get these silver amalgam fillings in their teeth, back when I used to get my teeth filled as a kid, occasionally the dentist would slip and a little bit of that amalgam injected into your gum. And then you'd get a brown or blue thing years later, and somebody biopsied, well, so it could be a blue nevus or maybe a melanoma. And sure enough, they biopsied, and this is what it looks like. It's basically a silver stain of the elastic fibers. Today, the place we're seeing this most commonly are people that are using these silver-containing eye drops or nose drops, and they get the cutaneous argyria that develops from taking systemic silver, or they're getting a piercing and they get a localized argyria from silver that's in the metal in the piercing that they put in. So you can get it in that situation also. But this was a mercury amalgam tattoo from a dental filling occurring in a mucous membrane site. So silver amalgam, make sure you can recognize that. You're going to get this on the board, may as well expect it. They love to show parasites. They love to show bugs because you can't argue with them. And here we've got a bug sitting in the cornified layer. So this bug is scabies. And hopefully you could recognize this. You're going to get this on the exam. Either they'll show you a scraping, they'll show you a biopsy with the bug sitting up here, or they'll show you maybe an egg or a sibilla. So this is an example of scabies. Pretty classic. It is classic. Okay, so there's the other choices here, things that can burrow. Tungiasis, obviously it's not that. That's sitting way down in this area. It's much bigger. Myiasis also way down here. That's basically a maggot sitting in your skin. It's not Demodex. That's inside a follicle. This is in the cornified layer here. It's not Calyatelia. That organism looks like a little rocket ship. And again, it's not sitting in a burrow in your skin here. This is pathognomonic of scabies. So make sure you can get that right also. All right, number 39 here. Okay, here we got it. So this is a nice example of pre-tibial myxedema in contrast to that digital mucus cyst. We did that focal digital mucinosis. Look at this. It's present, first of all, in the pre-tibial area. There's stasis altered change, but notice the mucin is present diffusely here. It's not a puddle of mucin like here. It doesn't have a lot of fibroblasts with it. It's just a deposit of mucin diffusely because the person's got hypothyroidism. Okay, so it looks totally different than the last mucin that we saw. So location's different, the pattern's different. Beautiful example of pre-tibial myxedema. I'm not sure anything else listed there should really have even come to mind when you look down at your choices in this case. So it's a good example. You may not have seen too many biopsies of this, but this is what it looks like when you look at a biopsy of it. It's just when you look at the patient, they've got this diffuse, massive collection of mucin sitting there in their pre-tibial area. They look like basically a mountain range of all the skin that's really markedly thickened because of the mucin that's deposited. This is another example of an inflammatory skin disease at low power. It just looks fantastic for palisaded granulomatous dermatitis. Rings in the dermis. Hopefully, even at low power, you immediately said, that looks beautiful for granuloma annulare. So when we're looking at palisaded granulomatous dermatitis, you want to look and see what's in the center of the palisade. Here it's mucin. You've got 2 or 3 or 4 little rings here sitting in the mid-reticular dermis, which is the classic location for GA. You've got lymphocytes. You don't have any fibrin like you might see with rheumatoid nodule. It's not situated way down here like you might see with rheumatoid nodule. You don't see any neutrophils like you might see with interstitial palisaded granulomatous dermatitis. This is pretty classic for GA. It's actinic granuloma. Now, a lot of people consider that to be a form of GA on sun-damaged skin. Usually that's going to have a lot of sun damage, so hopefully they wouldn't ask you to distinguish that in GA, but if they do, make sure you see sun damage with evidence of elastic fibers within the histiocytes. You need to see that for so-called actinic granuloma. It's not epithelial sarcoma. That's going to be a deeper process with atypical cells. Beautiful example of GA here. So hopefully that's pretty straightforward for you, and you were able to make the distinction of that even though you had some distractors that could be somewhat challenging. Okay, so again, these are classic examples of diseases here that they're going to show you. We've got a deep punch biopsy of a paniculitis. It's a septal, mostly paniculitis, a little bit of periseptal involvement, but the vast majority of the inflammation is involved in the septa. At low magnification, you see this, I want you to think erythema nodosum until proven otherwise. Go down to higher magnification, it's got some granulomatous inflammation, the so-called Miescher's radial granuloma. You can sometimes see eosinophils in erythema nodosum. I mean, this is just as good as it gets. They're not going to show you anything that's not going to be something that's just a classic example of something like erythema nodosum. Doesn't really look like any of the other choices here to look at. So we've already seen an example of polyarteritis nodosa. Doesn't look anything like this. Okay. Another paniculitis. Notice that this one has got a very, very diffuse involvement. The fact this is a gorgeous biopsy. And so when they show you examples of paniculitis, this is the kind of stuff you're going to get. It's a lobular, mostly paniculitis. Notice that there's the diffuse involvement of the lobules here. And there is also vasculitis here associated with this. So this is a blood vessel that's inflamed. It's so inflamed, it's really hard to even appreciate that it's a blood vessel anymore, but it's sitting here in the septa of the subcutaneous fat, associated with extensive lobular paniculitis that's got suppurative granulomatous inflammation. This is a fantastic, beautiful example of erythema induratum, or nodular vasculitis, which is the other term for that. These are often associated with underlying things like tuberculosis or other kind of infections. So this is, notice the difference between the extensive involvement of the septa here, as opposed to the case we saw before. So this is a nice example of erythema induratum or nodular vasculitis. Okay, good example of that. Punch biopsy. Almost no inflammation here. Start looking at higher magnification. The abnormality is not really an inflammatory disease. It's really an abnormality of the connective tissue. So if it's in the category of inflammatory disease, more in the fibrosing, sclerosing category, which remember we put morphia and NSF and those things in an inflammatory disease. But here we've got these classic pathognomonic findings of these coiled, elastic, calcified elastic fibers. This is pseudoxanthoma elastica. So this is just like the ochronosis. You need to hit, print screen in your brain here and be able to remember these so that you don't forget it when they show it to you on the exam. It's classic. Nothing else does this except PXE or a PXE-like reaction, which you can sometimes see in other diseases. So sometimes we see scars in C-sections of multiparous women, and they see focal areas of degenerated PXE-like change. They don't have PXE, but they get focal PXE-like change. You can sometimes see PXE-like change in NLD, surprisingly enough. But the main thing is to recognize these are PXE elastic fibers. You can get PXE from people that take penicillamine, and there you usually see the so-called bramble bush morphology, these little small little bubbles, if you will, little brambles that stick to the side of the coiled elastic fibers. I don't see that here, so it's probably real PXE in this individual. Beautiful example of that. It's not elastofibroma dorsi, which are giant elastic fibers in the dermis. That's kind of a soft tissue tumor, if you will. This is classic PXE morphology here. Shaved biopsy of what looks like a neoplastic condition, but you start looking at higher magnification, and it's got lots of multinucleated histiocytes that have this sort of amorphous, they're not really multinucleated, they're really large nuclei, maybe it was 1 or 2 nuclei, but they have this amorphous pink cytoplasm. And this is an example of a reticulohistiocytic granuloma. There's no Teuton giant cells here, so that militates against an xanthogranuloma, if they have that as a choice, which we did put it down here. It's not GA, it's not an epithelioid cell histiocytoma, so you have to recognize that these are the cells of a reticulohistiocytic granuloma, this sort of pinkish amorphous cytoplasm with no Teuton giant cells. These usually occur in multiplicity in patients that have terrible arthritis. So they might show you a picture of somebody with a bad arthritic condition and then show you a biopsy of this, and you're expected to know that that's the answer for that. So that is a reticulohistiocytic granuloma. Okay. Another punch biopsy, so we'd favor it might be an inflammatory skin disease here. And notice that there is this marked sclerosis of the collagen here. Now, there's sun damage here too, but there's primarily dense sclerotic collagen. I'm wiping out some of the subcutaneous fat here. See the sweat glands that look like they're sitting in the center of the reticular dermis. They shouldn't be there. They should be situated in the subcutaneous fat. This is an example of scleroderma or morphia, one of the sclerosing disorders. Note that it's got the marked square biopsy appearance here. So again, the choices that you had were scleroedema, scleromyxedema. Again, this is not a markedly thickened dermis like you'd see with scleroedema. There's no increased collagen, there's no increased fibroblast here. There's sclerosis, which is hyalinization of the collagen and loss of the fibroblast. That's what you see with sclerosis. So we don't see that that you would see in scleromyxedema, where you get an increase in fibroblast and histiocytes with mucin. So we don't know for sure whether this is morphia, where the person's got lung disease. All you can say is just in the family of scleroderma, that was your choice here that you were given. Okay, punch biopsy, things look kind of clear at low magnification. It almost looks a little bit like the GA case we had before. We start looking at higher magnification, and There are all these cells in the so-called busy dermis differential. You got these spindle-shaped cells moving north, south, east, and west, kind of like a busy bees flying through the dermis with this mucin in here. Mucin plus lots of cells going in all different directions without a lot of epidermal involvement. This is a nice example of scleromyxedema, papular mucinosis, lichen myxedematosis. They're all part of the same family of diseases, and they're all associated potentially with paraproteinemia. So again, they could possibly show you a picture of this, show somebody's face with leonine facies, might ask you the appropriate workup here would be, and then they might expect to do a SPEP and UPEP to rule out their underlying paraproteinemia. So nice example of scleromyxedema. Beautiful example of that. Doesn't really look like any of the other choices there. Okay, another deep punch biopsy here. And we've got a deep inflammatory process. And if you go to higher magnification, you see that there's palisaded granulomatous dermatitis. And in the center of the palisade here, instead of mucin, we've got this pink amorphous material, which is fibrin. And so when we're looking at these palisaded granulomas, we like to look to see what's in the center of the palisade. And here we've got fibrin. So the best answer here is rheumatoid nodule. Okay, hopefully this wasn't too difficult for you either. Notice how deep the inflammation is here. So GA, usually, unless it's a subcutaneous type of GA, doesn't get this deep. And you never get fibrin in the center of the palisade with GA. So this is a beautiful example of a rheumatoid nodule. Rheumatoid nodule. Okay. Next case, we've got a shave biopsy of what looks like a superficial perivascular infiltrate. You can see that these cells don't look like lymphocytes. They're not that dark. Go to higher magnification. There's really not much epidermal involvement. But notice that these cells are really pretty monomorphous. They look like little clones. One looks pretty much like the next one. And you start looking at as high magnification as we can go here. But the individual cells have got these features that look kind of like fried eggs. They've got central nuclei surrounded about this slightly granular cytoplasm. And some of them, cut in longitudinal section, look like hot dogs. So these are all mast cells. So you look down at your choice of answers, and you see that is a choice, mastocytosis. Now, you might get confused with these to say, well, hey, well, these look kind of like plasma cells, but they don't have the clock-faced nucleus, and they don't have that pink paranuclear halo that you get with the immunoglobulin in a plasma cell. They don't look like Langerhans cells, and there's no epidermotropism that we would see with Langerhans cells, so those two are out. So your best choice here is mastocytosis, even without a mast cell stain, okay? Now, they might be kind enough to show you this with a stain, but if they were tricky and decided not to, since you're bleeding in practice, recognize that these are mast cells and you can diagnose them without the crutch of a special stain, okay? So these are mast cells, and that's mastocytosis, and there's way, way too many here. And these aren't just a slight increase. There's a massive increase in the number of these cells here. Okay, our next one, we've got a punch biopsy of a blue lesion here. Blue is bad, especially when it's a neoplasm. And we got a punch, so we don't know about, breadth, symmetry, circumscription, but it doesn't look so symmetrical here when we look at it. It's bottom heavy. Bottom heavy plus blue, bad, not good for the patient. Let's go to our magnification and see what we can see. And notice that these cells they've got these very indiscrete nuclei here. They look smudgy, they look purple, they don't have really good nucleoli. This is classic for what we see with neuroendocrine differentiation. This is a so-called trabecular pattern of growth. Trabeculae are present between the individual aggregation cells. Cells are dying, necrosis on moss there. This is a deep lesion. So you look at your choices here. It sure as heck ain't any basal cell that we've ever seen. A B-cell lymphoma might look like this, but you don't get the smudgy chromatin in those cells. You can usually tell that those are lymphocytes, so that's not the best answer. And you don't get the trabecular growth of the B-cell lymphoma. There's no sebaceous differentiation here, so it's not sebaceous carcinoma, and it's obviously a malignancy. So this is Merkel cell. Merkel cell. Caused by polyomavirus in a lot of cases. They might ask you that. Make sure you're aware of that. Might ask you stains. Cytokeratin 20 paranucleotide pattern, synaptophysin, INSM1, those kind of stains. So make sure you're aware of all those things for Merkel cell. And thyroid transcription factor 1, usually for metastatic small cell carcinoma. Okay, kind of an incisional biopsy. Thin skin, pale cells, we think maybe histiocytes. Higher magnification, and sure enough they are. And they're loaded with foamy material. Foam. That foam is lipid. Lipid on the eyelid, best answer, xanthelasma. You had that as a choice. Now you had some other choices. You had eruptive xanthoma. Sorry for the misspelling. It's not eruptis. It should be eruptive xanthoma. That does not give you this type of diffuse infiltrate with the foamy cells. You get cells that often have bluish material because the cells come in and they rupture because they're so rapidly filled with triglyceride that you're actually kind of a bluish gray extracellular lipid in that. And there's also some inflammation. This has no extracellular lipid. So that's not the best answer. Eruptive xanthoma, not the best answer. And certainly it's not a xanthogranuloma or any of the other choices that you had. So beautiful example of xanthelasma on the eyelid.